Good evening. Welcome all to the webinar. I would like to thank all the attendees who have joined us today from various parts of the world. And I can see people from UK and US, Malaysia, Nigeria, and different parts of India. And they've all come in on a Sunday evening. Thanks a lot to listen to what our panelists have to say. And I would like to really thank my colleagues who have helped me organize this webinar. I'm Dr. Shalini Joshi, internal medicine consultant, currently working at Fortis Hospital. I'd completed my post-graduation in Cleveland Clinic, Ohio, and subsequently moved to Bangalore 10 years ago. Currently actively engaged in field of diabetes, tuberculosis, and my passion is tobacco cessation as well. I would like to start from the very beginning, as our topic of our webinar today is SARS-CoV-2 diagnostic and therapeutic dilemmas globally. So it was 31st December 2019 when a pneumonia of unknown causes, that was the report, which was delivered to WHO office in China. And today is 12th July, almost more than 6 months have passed. And no other pandemic has affected people in so many countries. Never has the world shut down like this. Every country has tried their best by taking different paths, calibrated or otherwise. Ebola, SARS, MERS did not kill millions because I think the shutdown was done promptly, and yet we did not learn. World leaders' responses have ranged from measured to downright idiotic, and vibrant towns had become ghost towns. Factories have closed, economies have taken a major hit, airlines have been bankrupted. Yes, we have learned to wash hands, and we really don't need much to live. So, despite the lockdown, we have discovered that we can satisfy all our needs in the Maslow's hierarchy. Now we have done everything: telemedicine, telecommuting, connected to our families on social platforms, working from home, connecting communities and lighting lamps. And we witnessed collapses of supply chain, but we also saw that the society has a heart. A lot of NGOs have come in to help. A lot of people have donated. People are working tirelessly. So with that, I would like to introduce my first speaker for our webinar today, which is Dr. Rama Kudipudi. She joins us now live from New Jersey. She is infectious disease American board certified, and she has done her internship and residencies in Jersey Shore University Medical Center, New Jersey. And she's a college graduate from Andhra Pradesh, Ramgarhia Medical College, and currently associate physician specialist at UMDNJ, New Jersey, and working at CentraState Medical Center, Freehold, New Jersey. Now, welcome, Dr. Rama, and I'm so glad you could make it today. Thank you so much. I hope I'm audible.
Thank you, Shalini.
With that, we go to our next speaker. Hi, Dr. Maneesh. He's a consultant physician working in North Middlesex University Hospital, London. After doing training in Mumbai, he has been working in UK for the last 17 years in a part of North Central London. He is passionate about thrombolysis. He's on working in one of the most deprived and diverse boroughs in England, and that population is at a very high risk for COVID. Married to Dr. Rupa Nair. She's a consultant obstetrician and gynecologist, and he himself is an avid reader and a cook. So welcome, Dr. Maneesh Bhargava. I'm so glad you could make it.
Thank you very much.
And now I come to my third panelist of the webinar. And I think in Bangalore and in nationally, it doesn't need any introduction, but I'll still go ahead and attempt to make an introduction. He's the chief of Dr. Ravindra Mehta, chief of critical care, consultant pulmonologist, sleep medicine specialist, Apollo Hospitals, Jayanagar in Bangalore. He's currently working there. And he is American board certified, not double, triple, in 5 specialties: internal medicine, pulmonary medicine, interventional pulmonology, critical care, and sleep disorders. Former faculty and assistant professor, State University of New York at Brooklyn. He's done fellowship in pulmonary medicine, as I mentioned, and did his internal medicine in Brooklyn, New York, USA. And he's done his MD from Mumbai, so he's a Mumbaiker, and MBBS also from Mumbai. So welcome, Dr.
Thanks,
Ravi
Shalini.
Mehta. Glad you could make it. I know you've been very busy lately.
My pleasure. Thank you.
With that, I come to Dr. Sachin Jhawar.
Hi, thank you so much, Shalini.
My very good friend as well. He's a director of Apex Hospital, has done MBBS from SMS Medical College, and completed his MS from SMS Medical College, and went on to do MRCS Edinburgh and AFRCP Ireland. He specializes in laparoscopy and bariatric surgery, and he's an awesome personality. I think you will just make that opinion after you listen to him, how he talks. And welcome again.
Thank you so much.
And last but not the least, a very dynamic young personality, Dr. Kunal Sharma. He's serving as a section head consultant oncopathologist at SRL Diagnostics, Bangalore. He also is in charge of the Reference Center of Excellence for Uropathology of Fortis Hospital. We depend on him. He's an expert here, delivering talks as a guest speaker, keynote speaker at numerous national and international forums. His very good study, a very peculiar one on diffuse large B-cell lymphomas with double and triple hit, was presented at International Congress, New York. Numerous publications, I can go on, but the most important thing, he is a member of the COVID consultative group advisory to the government in charge of COVID detection programs, working closely with the policy makers, and had a major role in making those KRTC buses and all those things he's doing for rapid detection of COVID. So welcome, Kunal.
Thank you so much. Glad to be here.
Okay. With that, I think we will go on to our first panelist and ask her the $1,000,000 question. Now, Dr. Rama, I would be calling you Dr. Rama in Indian style, Dr. Kudipudi.
That's good.
Please tell us what exactly went through your mind, and how did you guys all manage the overwhelming number of patients who showed at your doorstep in New Jersey in early March? Floor is all yours.
All right, thank you, Shalini. Early on, my hospital was hit hard, and one of the few hospitals that was hit hard. And that's when we recognized that treating patients with COVID presented a total different ballgame and circumstances, and it needed a very high plan of care on in this situation. So that's when we started to brainstorm and do what we call as COVID teams. That's what we started to do, which is a team of physicians that comprised of 2 primaries, 1 infectious disease and 1 pulmonary care. They were dedicated specifically to treat patients with severe COVID-19. And we, a bunch of ID physicians, also brainstormed on how to approach the patients with COVID-19 from infection control standpoint, from diagnostics at therapeutics, and yet also we had to know how to deliver a compassionate trial on these patients. We also had to limit the number of providers that were going into each room. So we had to even limit, that would limit the exposure of our healthcare workers. And initially we had issues with our PPE, so that in this COVID team has helped us preserving our PPE as well. So that's how we started to do. And then in dedicated COVID teams and dedicated COVID floors was how we started our strategy of combating with this pandemic.
Okay. Would you like to on your PPT or should I?
Yes, I would go ahead and.
Because we would love to hear all your experiences with all the antiviral steroids and the anti-inflammatory which you have been using. What did you do in early March and how have you evolved in treating your patients in June?
Okay, so this is what I just wanted to get a little bit an introduction on what this coronavirus disease 2019 is. It's a novel coronavirus. Now it's called the SARS-CoV-2. The first outbreak was in the Wuhan city, the Hubei province in China, and it actually the WHO knew about it. It was initially reported in December of 31st of 2019. So a month later. WHO declared this outbreak as a global health emergency. And March 11th is when the WHO declared a global pandemic. So I think I'm having a little bit of glitches here. So basically we're looking, I think there's a slide that is missing, but that's okay. I'm just going to talk about it regarding the COVID. What was the incubation period is ideally it's 2 days to 2 weeks. That was your initial incubation period. So, and there is an acute phase for it and then was the inflammatory phase. So we were seeing patients during our 7th to 9th day. That was on the cusp of inflammatory phase, where the patients were coming in with dyspnea, hypoxemias, obviously with fevers, sore throat, myalgias as well. So we had to, although we know that there was no approved treatment options at that time, so we started to initiate a certain protocol based on the literatures from Wuhan and Italy. And we started with oxygen, hydration, and as we know, vitamin C is known in the sepsis protocols or sepsis study that it decreases the oxidative stress. So we have added that to the regimen, and zinc, known with its antiviral properties, and it boosts the immunity, we kept it on. So the drugs that initially that we used were the hydroxychloroquine with or without azithromycin, as well as lopinavir, ritonavir, which was Kaletra. And for patients with COVID storm, which were in a massive inflammatory phase, is when we used the tocilizumab. We were fortunate enough to be enrolled in the compassionate use of remdesivir trial, wherein the patients who were severely COVID positive as infections and were on ventilator were given 10 days of the remdesivir through this compassionate use of the trial. And followed by which we got ourselves involved in our expanded access program of the convalescent plasma trial. Early on, we did not use anticoagulants or the steroids, but following, this is a curve, in early April, we started using around this time the steroids and anticoagulants, and actually the amount of patients that were being ventilated actually decreased. So that's when our anticoagulation and steroids got on board. So from that, what we learned, initially our hydroxychloroquine had an emergency utilization authorization in March itself, so we could use the drug, but as of June 15th, the FDA has revoked the emergency use authorization for hydroxychloroquine or chloroquine here, as it showed no beneficial effects in hospital stay, nor mechanical ventilation, nor prevented hospitalization or deaths, and even they looked at the post-exposure prophylaxis and did not show any benefit. As of now, WHO has halted all the hydroxychloroquine trials, but I heard 2 weeks ago that they are doing the hydroxychloroquine trials only in UK. The IDSA, which is the Infectious Disease Society of America, has said that hydroxychloroquine can be used only under clinical trial settings at this time. Now, the Kaletra or lopinavir or ritonavir, now the NIH panel, which is the National Institute Health Panel, has recommended against the use of Kaletra, as it did not show, the clinical trials have not demonstrated any clinical benefit at this time. There was a randomized control open label trial that was done, but however, it did not show any statistical significance in terms of its mortality. There was a study of multi-center study in Hong Kong, which was done comparing 14 days of triple therapy. What therapy they've used is Kaletra, which is lopinavir ritonavir with ribavirin and interferon versus Kaletra alone. And what they found was there was the triple therapy arm had significantly shortened the duration of viral shedding and hospital stay. However, there was no impact on the levels of viral shedding or clinical course or survival changes. So I guess we need more studies and data for using such kind of toxic triple therapy at this time. Now coming to the interleukin inhibitors that we have been using, the common one that we have used in our institution was the tocilizumab, which is the Actemra. And as of now, NIH guidelines, since there was insufficient data, they're not either recommending it or for or against the use of this IL-6 inhibitors. However, there are a lot of trials have been underway with this drug. In my hometown in New Jersey, there was an observational study done wherein 134 patients who have received tocilizumab in the ICU, the survival rate was 56% to those compared to the ones who have not received it. So with the tocilizumab comes the territory of increased incidence of superinfections. But however, the case fatality rate is actually not significant. So what we have seen in my institute was, yes, bacteremias were common post tocilizumab use, fungemia in certain patients, and even have seen viremias. But all of them, viremias, is we decrease their immune suppression. For fungemias and bacteremia, when treated appropriately, they were discharged home. So there is another interleukin inhibitor that is being used is acerulumab, and it also has shown in phase 2 data that it massively decreases the C-reactive protein levels. Patients had less ventilator time on the acerulumab arm. The discharge rate was about 53% compared to the 41%. So our remdesivir trial, compassionate trial that we use now, this is the data that came out in New England Journal, where it did show that 53% patients were involved, had showed 68% clinical improvement with the remdesivir. So what happened, so as of May 1st, the remdesivir compassionate trial was stopped, and FDA has approved for emergency use utilization for COVID-19. And this was based out of the data that showed that remdesivir has a 31% fast recovery time compared to, so it was 11 days in patients treated with remdesivir compared to 15 days. So that was a 3-day difference. So initially the remdesivir was only for intubated patients. There was a simple trial that was done looking at patients who had severe COVID, but non-intubated patients. And they were given 5 days of remdesivir trial, and it showed 65% more likely to yield clinical improvement on day 11. Hence, now we can use patients on remdesivir for 5 days. Now, there is a phase 1 trial going on in terms of inhaled nebulization and to be used for early stages of the disease. Then we have the steroids. There's a major UK recovery trial that has come out regarding dexamethasone, where it showed that it reduced deaths by 35% in ventilated patients, 20% in the patients who had received oxygenation, but there was no benefit in patients who did not receive respiratory intervention.
Okay. That was a nice overview. And I think I will have a follow-up questions
Sure.
for you, Dr. Rama. Thanks for the broad overview. And with that, I go to Dr. Maneesh Bhargava. I would really like you to elaborate, or rather tell me what exactly your hospital did to, how did the management and how did your community and support you and the doctor community when the overwhelming numbers were presented in UK early on in March? Basically, 3 things what you did in your hospital. You have to unmute. I think you're unmute.
Okay, can you hear me now?
Yes.
Okay, so I think we were hit quite badly in March 3rd week when we were actually not expecting the peak that early. So the hospital was caught a bit unaware, but management, they did change things fairly quickly, and within a couple of days' time, all the rotas of junior doctors, everything was changed, and hospital was divided into sort of 4 different zones. And all the teams, all the doctors who were working in different specialties, they were pulled together actually, and an emergency rota for physician as well as the juniors was made. And apart from that, nationally, they did ask lots of retired sort of doctors and nurses to come back to the system, which did provide quite a lot of help. And the final year medical student who passed, actually, they were passed without any exams. And then they were also drafted in as interim sort of interns really to help out the teams who were already in the hospital. And apart from that, one of the most amazing thing, which probably is quite British, is the support which was provided by the community in terms of providing hot food every day, providing tea and coffee throughout the day, so that junior doctors, all the nurses, or anyone who was working in the hospital, they never went hungry. And I think the support which was provided through the community was one thing which helped us go through the pandemic for a number of weeks.
Okay, thank you so much. With that, I will go on to Dr. Ravi Mehta, and we'll just go ahead straight to the point. Happy hypoxia, silent hypoxia, people not getting short of breath with saturation of 68 to 70%. What are our options? HFNO, if not available, FNC, you're proning, intubating. Please go ahead.
I think before we say that, Shalini, you have to understand these terms a little better. So I think the story of COVID has been full of these catchy phrases, interesting terms based on a changing pathophysiology. So if you see that, what do? We like what we know. So we say it's acute lung injury, and we say this is what we have to treat. Then actually on-ground observations come with say these patients are not behaving like a typical acute lung injury. So that's question. And then these terms come out called happy hypoxia, which are lovely to listen to, but unfortunately patients are not listening to us. They're not all happy hypoxemic. We have plenty of unhappy desaturators at this point who are symptomatic and tachypneic and tachycardic. And then it came down to why are we bringing this whole thing up? It's because like Rama was trying to point out, it's all exercise of pathophysiology and who is showing what at what stage. So if you look at the whole story of COVID and put it in a few lines, it's a viral infective attack at that point. It triggers multiple pathways, which we realize are very different from what was there before. So we have a viral infective pathway. It leads to inflammation, and that led to the steroid component she talked about, used very profoundly as against other ARDSs we have seen. Then in the midst of that came this white clarion call of thrombotic, endothelialitis. It's a thrombogenic disease. There is intravascular thrombosis. And then that whole cycle picked up, and that is what was the genesis of those happy hypoxemics. And then they said that the COVID guy is not listening to us. Suddenly in the midst of it, he goes nuts and he goes into a cytokine storm, so watch for it. And then when all is done and dusted, they wind up on ventilator. And when they're on ventilator, you have very few options. In the midst of that, small things came in like convalescent plasma. Let's try and give the immune status a boost and so on and so forth. So this whole thing is an interactive pathophysiology of infective, inflammatory, thrombotic with a various combination of those which we can't figure out at this point. And that is the problem. If we could figure out who's at what stage, we would use the drug. And typically in a pandemic of this sort, which sweeps the whole world, the practical implementation of the science precedes any data. So we are now stuck with tons of papers, retractions by the biggest guys of the world, confusion more than clarity, and we're trying to make sense while we are inundated with these guys sitting in front of us who don't care anything, don't care about what data is there, they want outcome. So this is where we are stuck. So now to come back to the original question of hypoxemics, they are only a fraction of the whole thing. And those are the guys basically who are more of the endothelial lattice and the thrombotic issue than the acute alveolar interstitial pathology, which is so typical of ARDS. So when you actually come down to brass tacks, what you have to look at is when you see a patient is what's going on, what is the pathophysiology we assume? Are you going to use the antiviral strategy, mix it with the anti-inflammatory strategy, and then think of the anti-thrombotic strategy? So typically for these hypoxemics, if you assume thrombosis is more, which is indicated by first a clinical evaluation, which is only suggestive but not definitive, you will then do all the markers which are there. And the only one to help us at this point besides the inflammatory ones is the D-dimer number. If the D-dimer crosses a certain number, we start giving anticoagulation, double dose anticoagulation. And provocatively, in the part of the world Rama comes from, they've gone on to TPA and so on and so forth. Even the 6 major centers like Sinai, Hopkins and all have different protocols based on their experience and data on the ground they have at this point. So this is what's going on. So interesting term, but for the practitioner who dives into COVID, it's just an aspect of pathophysiology and clinical medicine to take into context and treat accordingly.
Okay, thank you so much. From a complex critical care situation, let's go to the situation which we are facing now, which everybody, because our facilities are overwhelmed, home, point of care. So Dr. Sachin, I know he's a straight shooter, so let's go right on. So would you like to elaborate like the 3 most important aspects of home isolation? How do you monitor positive asymptomatic and mild symptomatic patients? Could you just elaborate 3 aspects of that?
So in country like India, where the resources are so scarce, I think home isolation is much more important than any other country, any other part of the country, probably barring a few more developed countries. And our situation is pretty unique in a way that unlike any advanced country, one, we are not technologically very savvy. Second, we live in crowded stroke. Most of the time we live with the family. The third thing is people panic too much and there is too much information that is available. So it is very difficult for actually people to stay happily in home quarantine. Everybody would like to go into a hospital. So I think very strict regimens for home quarantine where treatment is done regimentally, that is one thing that is very, very important, and people have to be told that there is no need for them to come. It has to be very clearly marked that these sort of patients should not be admitted to the hospital. So it is not about home quarantine. It is about which patients need admissions. Once you define this, rest everybody needs to be home quarantine. If you can understand what I'm trying to say. Otherwise, anybody with positive, they will try to land up or at least enter into a hospital. And at the same time, the practitioners, hospitals, everybody needs to be lavishly supported by technology and by resources to actually make sure that these patients are taken care of at home.
Okay, thank you so much. With that, I'll go ahead and have the luxury to ask you the second question now only. So I know, Dr. Sachin, I follow on social platforms, and you've been very active in engaging the public, your nurses, your junior doctors. You are a hands-on leader and director of Apex Group of Hospital. Tell us, how do you train and retain your health care professionals, even in the housekeeping space, in these difficult times? Because we have seen so many people leaving the hospital.
Shalini, it's so true. See, most of the principles of management have actually come from military. And, retaining staff, engaging staff, and ensuring that they work in these times, it has to come straight out of the military book. So, people who serve in the military, there are several causes, and I will not go into the details. But why most of the surveys, research, everything says three things why a person is ready to die for his country. One thing is he is really very well decorated. He is appreciated for the effort that he's doing. One thing. The second thing is the person who is ordering him to go on the front is in front of him. He is not sitting at the back in a air-conditioned office, well away from the thing. His leader is most of the time ahead of him. The third thing is he ensures his families will be taken care of if something happens to him. This is like the same thing has to be done for our doctors as well as for our nurses by the country, community, and the hospital.
Okay, thank you so much for answering it so beautifully and to the point. Dr. Kunal, could you unmute yourself? Yes, welcome. So, Dr. Kunal,
there I am.
we have many lab tests done, and we have so many in the armamentarium, but the gold standard being RT-PCR. Now, please tell us about the new kit on the block. The buzz is all about the antigen detection kit. So, could you please go ahead and start telling us until we upload your.
So I would just like to briefly tell about the various kind of diagnostic tests that we do in relation to COVID-19. While there are the routine tests that are available, which start with lymphopenia in the blood plus raised C-reactive protein, along with that raised liver enzymes. And in the later stages, we usually see raised D-dimer, raised CRP, raised liver enzymes, and lymphopenia, absolute lymphocyte count of less than 800. But for the specificity, we do certain types of tests, which if you can go on to the next slide. Yeah, so there are the molecular-based tests, which include the RT-PCR and the TrueNat, including the CBNat. Then we have the antibody-based tests, which we can do on the ELISA platform or the CLIA platform, and we can actually provide you the titers, which might be important from the plasma therapy point of view. And after that, we have the rapid kits, which are now available, especially given the scenario in a country like India, where the population is just too much to handle. These kits definitely have an important role to play. In the rapid test kits, we have the rapid antigen detection kit, and we have the rapid antibody detection kit, which can detect the total antibody as well as the IgG. So with this brief, as we all know, RT-PCR is the gold standard right now for testing with a reasonably high sensitivity and specificity. It even detects, ideally it should be done a little later in the stage, around the 6th and the 7th day. But even in early stages, window period where we might not have a proper antibody titer and the rapid antigen might not detect the virus, RT-PCR is something which might be able to detect the virus. TrueNat, to tell you just shortly, TrueNat and CBNat are basically glorified forms of RT-PCR. This is a cartridge-based test. The important thing is that it is very fast. While RT-PCR would probably take around 5 to 6 hours for turnaround time, something like a gene expert can provide you answers in 45 to 50 minutes of runtime. But the limitation is that there are only certain limited number of cartridges that we can put at one go. So then is the rapid antigen kit, which I would like to highlight in detail, because that will be the point of focus, at least from the Indian perspective. The antibody kits right now are not approved for detection per se, as per the ICMR guidelines, but we can definitely use them for serosurveillance, and they give a good idea in conjunction with the clinical features and a negative RT-PCR status once the patient is recovering from the illness. With that, I would just like to highlight a little on the antigen testing. Next slide, please. So this just shows that while RT-PCR remains the gold standard for testing, it is something that needs a lot of financial investment. We need biosafety level compliant facilities, and we need very highly skilled technical manpower. So in a country like India, if we rely completely on RT-PCR, we will be grossly under-tested. And we know testing is the first pillar to combat this menace of COVID-19, as we have been following the dictum of test, track, and treat. So we had a necessity of a point of care testing. ICMR basically tested this in 2 studies, one with All India Institute and one with their own study. And they have validated a kit developed by SD Biosensor in India. The sample that we take for this kit is the nasopharyngeal swab. This has a specificity of about 99.3 to 100%. The sensitivity was variable from 50.6 to 84%. So here is where the question arises that is it a good test, especially in the asymptomatic in healthcare workers, because the chances of false negative would be high. But as per the ICMR guidelines, it is currently recommended as a point of care test for containment zones and the healthcare settings. I'll just briefly elaborate on what that is. Next slide, please. So in the containment zones, basically for all asymptomatic direct and high-risk contacts, especially the ones with comorbidities of lung, heart, renal, and hematological and other disorders. Then the ILI patients. ILI, we include acute respiratory infection with fever greater than or equal to 38 degrees Celsius and cough. Next slide. A very important role that the antigen testing has been touted to play, we are yet to see the practical efficacy of that, is in the hospital setting, where all symptomatic ILI patients presenting in a healthcare setting and suspected of having COVID-19 infections, this can be used as the point of care test. Also, the asymptomatic patients who are hospitalized or seeking hospitalization, this includes immunosuppressed, including HIV, malignant illnesses, including those on chemotherapy, transplant cases, and elderly with comorbidities. Another very important aspect is use in aerosol generating surgical and non-surgical interventions. That is the elective emergency surgical procedures like neurosurgery, ENT, etc. And even in non-surgical interventions, which have a lot of aerosols in them, like endoscopy and dialysis. Here, I'd just like to show in brief as to how we go about the antigen testing. So the sample that is taken is the nasopharyngeal swab. What we need to understand is that the way we take the nasopharyngeal swab is very important. Then we actually put it in a solution, and once we have that solution, we mix it, and then we have a card-based kit on which we put about 3 drops, and the test is read in about 15 to 30 minutes. We should not exceed it more than 30 minutes because then the chances of false reporting are very high.
And it's very easy to read because a naked eye you can read, right?
Absolutely. It's very easy to read, and we have to understand that even if the lines are not exactly regular and they are not very clear, we still have to consider it positive. So there is a control line and a test line, as you can see. Plus, the other important aspect is the way we take a nasopharyngeal swab. It has to be parallel to the palate, and it has to be at a distance of, so roughly we calculated from the ear to the nasal opening. And when we meet resistance is when we realize that we have hit the point of contact. Plus, we have to make sure that we let the swab stay inside for some time. So I've also shown the SD Biosensor kit, which is approved in India right now. Next. So this is the current algorithm that we are going to follow from the ICMR plus the state directive. That is, the first test or the point of care test would be a rapid antigen test. If it is positive, we have to consider it as a true positive and treat the patient as COVID-19. If it is negative, we have to see whether the patient is symptomatic or asymptomatic. If the patient is symptomatic, we have to have a mandatory confirmation by RT-PCR. But if the patient is asymptomatic, we have to declare him as negative, and we probably can also follow a little bit of our clinical judgment. If we still want to go ahead for confirmation, we can definitely go ahead with the RT-PCR. And these cases also have to be entered on the ICMR portal from the Indian standpoint. Next. So as we know, the hope should remain, and I hope we definitely will overcome this crisis.
Thank you so much for the Great overview, Dr. Kunal. It answered a lot of our questions which had come from the audiences. So good, we covered that all. With that, I will come back to you, Dr. Rama, in a bit. Dr. Maneesh, I know that you yourself and your wife has got infected with COVID. Would you tell us what have you? How did you overcome, and what have you learned? 3 things which you think you should have done or your wife have done, to have a better immunity. You have to unmute. Sorry.
Okay, can you hear me now?
Yes.
Yeah, so I think all of us, including my wife and both the kids, were infected, unfortunately, and took almost 6 weeks to recover completely. And the main thing was the fatigue, which was very unusual and very prolonged fatigue, really. So, I mean, one of the lessons which I have learned personally is I think the severity has got a lot to do with your level of fitness also. And as doctor, most of us, including me, actually, we are the one who actually don't pay too much of attention to our fitness. So one thing which I would definitely recommend to everyone is really to get as fit as possible, because that is one thing which is probably going to protect you. Second thing which you learned is deep breathing exercises, which are quite important to improve your vital capacity. And as far as whatever evidence I have seen, really, so some of the yoga exercises are quite important, because that will help in maintaining your lung capacity. And third thing, I think the third message or third learning for me was the support network which you need, actually. So we all think we have got everything and we can survive, really, but when you are in trouble, it's your support network which helps you. So we were not able to go out, so for some of the friends had to do cooking and bring food for us. And that's how we survive, really. So I think your support network, physical activity is important, and I think maintaining your vital capacity is quite important, really, if you want to survive the onslaught from COVID.
Thank you so much for sharing your personal experience and your story, and I'm so glad that all of you are doing well at this time. With that, I will go to the next question to Dr. Ravi Mehta. Dr. Ravi, can you hear me?
Very well.
Yeah, so, would you like to give us a brief checklist of all the differential diagnoses? So, the message being, do not stop entertaining other differential diagnoses. Please go ahead. You have 2 minutes.
So I think the whole thing comes down to whether we have, when you start admitting people, the entire emphasis was COVID hospital versus non-COVID hospital. And there's been a lot of talk on, it's very, very difficult to run non-COVID services with COVID services in an extensive COVID scenario. So we in India or many parts of the world have gone through this conundrum where COVID is coming in. You don't want to, obviously you want to continue non-COVID services. You try this segregation policy in the hospital, which works only so much, because ultimately cross-infection and staff issues and so many other problems which were pointed out by the others also show up. So that becomes a big issue. Then ultimately, if you turn COVID, it's much easier. But then the 2 types of people who come to you are COVID suspects or COVIDs. COVID suspects is anybody with this typical ILI, SARI, respiratory failure syndromes. And that's where you have to be quite alert over what's going on. Now, clearly in a COVID season, it's like, when you see animal on an Indian road, it's a dog and not a zebra. So most of the time when they're coming in, you're going to be seeing COVID and COVID. But once in a while, you're going to get surprised. And that usually is if you have a very savvy index of suspicion, you have a broad clinical knowledge, and there's very few providers we have now who have all that, because we're taking anybody who comes in. ENTs are coming in, cardiologists are coming in, no offense to any group, but anyone who comes in is allowed to do duty now. So you have to have that. And then the main thing is what may be Kunal's area. If the RT-PCR is repeatedly negative in a florid case, then you start wondering, what are you treating? Also, don't forget, there is no auscultation happening in COVID units. So the entire science of LENAC going on to, Abraham Verkey touting it in US extensively is gone. So recently we walked into a COVID unit with a very expensive electronic stethoscope, and some of us who still believe auscultation is a good clinical tool, are trying to use that or a Bluetooth to figure it out. So that's the whole catch out here. So you need the right people, the right knowledge, then the testing, and then so on and so forth. But as Rama was trying to point out, you wind up treating very fast in the sick people. So you'll be throwing in drug after drug, and then after a while you have to reevaluate the whole thing and see. And let's not forget, we're giving steroids very fast. If we're giving steroids to non-COVID conditions which don't need it, we are also complicating the issue. So much as we try to do this lovely COVID business, we are now getting surprises also. And on the ground, we need very, a higher degree of alertness, savviness, the right testing, and the checkpoints and the stop gaps to figure out that, okay, this is something else. And I told you one-to-one, we had a recent pneumocystis who got treated for 3 days as a COVID before we said, let's send that HIV test with RT-PCR being negative, and lo and behold, the whole thing shifted to HIV with pneumocystis. So it's an interesting paradigm, a space to watch out, work in progress, but certainly it's thrown up challenges above and beyond what have been already discussed.
Top five differential diagnoses which goes through your mind.
Well, so the regular viral pneumonias, and now, Rama's part of the world has NEGM telling us, guys, fall is coming, regular respiratory viruses are coming, regular flu is coming, H1N1 is coming, and COVID is there anyway. So it's going to be a nightmare at this point. So all your respiratory viruses, the known guys, the unknown guys, the wildcards are going to be there. Any other cause of acute lung injury or hypoxemia. And there we have all our other differentials such as COPD, asthma, ILD. So if you ask the top 5, it's going to be the respiratory viruses. They itself take up the first 4. And then the common mimics of asthma with infection, COPD with infection, ILD with infection, and other things like pulmonary embolism with atelectasis, so on, and heart failure would be the most common things to think about. I would put heart failure a little higher up here.
Okay. Thank you so much. And Dr. Sachin, I know you are a very hands-on administrator, leader, and blessed with very effective communication skills, by the way, which are not taught in our medical school. So tell us, how do you deal with the patients and families in their difficult moments? Because it is all the more relevant in our current scenario where there will be mortality.
So, fortunately, Shalini, here, the situation in COVID is very simple. So I think dealing with family in the COVID thing is very, very easy, because there has been enough publicity thanks to media and the whole world that it's been talked about and people are actually scared. It is the non-COVID patients which are coming to the hospital, and dealing with them is also a very big challenge. But that is the big issue. Whether we will get COVID, why do you want to do this? Why do you want to keep us in the isolation? Why there is so much social distancing? Why do you want us to wait? So in this COVID area, treating the non-COVID patients is a big challenge. As one thing Ravi said is very clear, you have to be either COVID or non-COVID. But all non-COVID hospitals also have to have an isolation area or a kind of a blue zone or red zone, where initially all patients need to be admitted till their RT-PCR is negative, and then they need to be moved into the white zone. So I think that area and dealing with those people, keeping those patients in complete isolation without the relatives is a big issue. Yes. So the repeated reassurance, video counseling, and here the staff that is treating them has to be very, very, very careful in communicating. There, the staff here treating becomes the relative, becomes the person giving the information. So that reinforcement to the treating staff has to go there in very plain and simple words.
Okay. Thank you, Dr. Sachin. With that, I go on to Dr. Kunal. So a lot of people are confused with when does it appear and when does it disappear. So I thought you could give us a very brief overview. You have 2 minutes.
So yeah, I have posted this chart for everybody to clearly understand that, of course, the first type of antibody that appears around the 1 week to 1 week time is the IgM, but that probably goes down and diminishes by the 21st day. That is about the 3rd week. And the next antibody that appears is the IgG. The titers of IgG are actually much higher than the IgM. So you can see that in the in the window period and in the early stage of the disease, IgG might not help too much, whereas IgM might help. But of course, the value of RT-PCR remains. So that's why antibody titers are not very useful when it comes to diagnosing the illness. Plus, there are, we are still in very early stages of understanding the disease. How long do these IgG titers remain? 3 months or more? The other thing is whether these are really the neutralizing antibodies against the spike protein or the nucleocapsid protein that we have. An interesting point of view that I was reading a few days back is the fact that people who have higher antibody titers are the ones who also have, higher chances of ARDS. And people who have higher antibody titers are also supposedly in future, we realize that there is a chance of a reinfection. These are the people who would probably present with a much more sinister form of the disease, just like probably the one that happens in dengue, when with a cross infection with another serotype later in your life might predispose you to presenting with dengue hemorrhagic fever. So that I would like to understand that the role of antibody is usually in understanding the kind of herd immunity that is being prevailing in the community for serosurveillance and for patients who are recovering, to understand what type of an immune response they have.
Okay. Thank you so much, Dr. Kunal. With that, I go to Dr. Rama. Would you like to comment and share your experiences very briefly in the interest of time with the pregnant ladies, pregnant female in any part of pregnancy? Did it change your protocol of treatment in any way?
We had a couple of pregnant patients almost towards the term, and they were the ones who had delivery. And if they were COVID positives, there was no change in the treatment guidelines. Remdesivir, right from day one, has said okay for pregnant patients as well as kids less than 17 years and above. At one point, hydroxychloroquine as well was prescribed for the patients who were pregnant, and no treatment has been changed that was different for the adults.
Dr. Maneesh, as we were discussing the other day, you were mentioning you have been seeing some interesting cases, like a lot of things have been unmasked by the COVID presentation, like sarcoma. Would you like to briefly share your experience?
So I think in last few months, we have definitely seen people who had undiagnosed immunocompromised state being unmasked. So I have seen people who had renal cell carcinoma being unmasked because of COVID. I had a patient who had first presentation of HIV because of COVID. And interestingly, we in at least locally in London, we have seen quite a few diabetic emergencies precipitated by COVID, either in new onset diabetes or people who are known to have diabetes. There in later stages, towards the end of May and June, we were seeing quite a few people with skin rashes and chilblain type. So I think that's something to watch out, unexplained skin rashes. And lately, because the peak has gone, we are seeing quite a few people presenting with neurological symptoms, especially we had cases with the Guillain-Barré syndrome, as well as peripheral neuropathy, especially sensory motor neuropathy. And we had somebody who presented with paraplegia with the completely normal MRI spine, as well as EMG nerve conduction. And I have seen people who are presenting as a stroke mimic also. So I think we need to watch out the space for lots and lots of unexplained neurological symptom and consider COVID and especially other thing which is quite relevant in India probably would be diabetic emergencies, really unexplained in somebody who's not known to have diabetes.
Okay. Okay. Thank you, Dr. Maneesh. With that, we go to Dr. Ravi Mehta. Can you hear me, Dr. Ravi? Like most of the people from ordinary pneumonias, recover without any lasting lung damage. The pneumonia associated with COVID-19, could be severe. And I think I was reading something with the Dr. Panagis from John Hopkins saying that a lot of scarring is happening, and after recovering, causing breathing difficulties that might take months to improve. So could you please comment on that briefly?
Yes, this is the sequelae of COVID or the after COVID part of it. What are we going to be left with? And we are all concerned that there, I think the pathophysiology comes down to the recovery of an inflammatory lung injury where the fibrotic phenomena takes over. I think that's where your viral attack is gone. The thrombotic part has taken a back seat in most people, except for the ones who had some DVTP, and you're left with the typical reparative fibrotic injury which the lung suffers from. And that's where the COVID leaders of the world, America, Spain, Italy will be looking at all those things. We're a little lagging behind when it comes to all that. The concern is fibrosis. It's following a certain pattern on a CT scan. These are the long-term guys where the inflammatory cycle has gone to the fibrotic cycle, and they could be left with just what's called a sequelae in terms of functional capacity, or some of them actually are not coming off ventilators. That is the main worry. Recently, a report has come, much touted in the newspapers of a Indian-based surgeon in Northwestern who has done 2 double lung transplants for COVID fibrosis. And so it's reaching that stage also. So this is going to be a typical ARDS fibrotic sequelae in a certain segment of the population, which healed with the scarring phenomena. And that's what we'll be facing in the downtime. Meanwhile, the more intriguing part is the people who are taking time to recover. That there are a lot of people complaining to us about the little shortness of breath and so on and so forth. Our feeling is again there where the inflammatory component is profound, they will get better. The only ones who are long-term crossing the 3-week window in ICUs and ventilators, they'll be left with the fibrotic phenomena. This is the writing on the wall right now, but I'm sure very soon in the next 3-4 months, we're going to get a whole bunch of reports on sequelae of COVID and is there a different phenotype compared to what we know in regular ARDS sequelae.
Okay. Thank you, Dr. Ravi. Dr. Sachin, I would like you to comment 3 things, like 3 positive things which should or could or would happen in India or globally, considering this pandemic. A lot of changes has been seen historically after World War II or any pandemic hits. Do you foresee, in your opinion, that there'll be better healthcare infrastructure investment? What are your thoughts?
So, Shalini, excellent question. And that is the only way to live in this world, whereas we look at positive things. See, it was early 2004 when India took the infection bundle, hand hygiene and everything was there. But it has taken 16 years and Corona to teach doctors and the medical people to just make them learn hand wash. So I am sure, like hand wash, like hygiene, like mask, lots of things Corona will probably teach us. And with the second most important thing is doctors and the hospitals, they themselves lack in medical technology so much. So technology is lacking so much behind, whereas industries like airlines, which grew up with healthcare, there are industries like cameras, which grew up, with as in healthcare, have tremendously developed healthcare, though cannot be compared directly to those kind of industries, has been lacking, which is primarily because of our preconceived notions. The doctors' preconceived notions were there, which were hindering the use of technology. I think technology will actually change the way we detect, prevent and treat diseases of the future. So I'm sure once all of this settles down, you will see a shift not only in diseases, in treatments, but majorly in outcomes. Because as Dr. Ravi said, we are now interested in outcomes. So hospitals, even in India, the people will talk about outcomes and not just facilities, degrees and resources.
Okay, thank you, Sachin. Now over to you, Dr. Kunal. I would like you to comment on how the dynamics and the policies in Karnataka and India changing with the changing face of Corona pandemic. Could you briefly mention?
So, the important thing that this disease has taught us is the fact that know so much more. You must have seen how many statements in WHO were given initially and then they were retracted. Sometimes they say it is a fomite-based transmission. Then they say it is airborne. I mean, they just go back and forth. So what we need to understand is we are still learning as we are going through. And from the Indian point, from the Indian and especially the state government perspective, there was a time when we were very conservative about our testing. We had the state surveillance testing approvals which were needed. So I had written a letter to the Honorable Minister, and we got that kicked out. So after that, the testing increased to about 40%. We have a very proactive government which works closely with the healthcare workers. So for that matter, it's easier to get the policies rolled out. We are now at a stage in which we are still much under tested when we compare the parameter with South Korea, which had tested nearly 4% of its population. So from an Indian perspective, we are looking at a point of care testing. That's why the emergence of rapid antigen testing has just come up in the forefront. On the policy making level, we are also becoming more relaxed with our testing. We have come up with an RT-PCR app on which the approvals are coming in probably 10 to 15 minutes. You have seen that with antigen testing, even elective surgeries and aerosol bearing procedures have been brought into the purview of testing, which earlier there was no guideline and there were no approvals for from an elective point of view. So I think as we proceed in time, the liberty is going to be there. There is going to be more liberty in terms of whom we can test and whom we cannot. Because again, I would like to stress that testing is the first and the foremost pillar on which the whole strategy to combat this menace lies. We are also coming up with mobile testing vans, mobile testing kiosks. So you will see quite a voluminous, role of testing in the community.
Okay, thank you, Dr. Kunal. Dr. Rama, would you like to? There have been a lot of questions on YouTube Live regarding the loss of sense of smell and taste. Those patients, would they be worried, get tested, or would you like to elaborate what are the other conditions which can lead to the same symptoms?
So it is known that COVID-19, what does it use? It uses the ACE2 receptors, which are abundant in our nose, our throat, and the bronchial tissue. That's where they are. So first thing they're going to do is that's where they are. So your nose that you're going to lose is loss of sense of smell, loss of sense of taste. And there are a lot of patients that have come in with anosmias and a loss of taste. And these kind of patients, from where what we have known is that the disease is known to be less severe. Hospitalizations are less severe if these are some of the symptoms that they do develop. And majority of them that I have seen is said within 3 weeks that their anosmias and loss of taste has reverted back to normal. However, there are some patients that you'd see is it takes a longer period of time, or it may not even revert to normal. There was a study in Detroit that was done, and which showed that, they looked at it. It showed that 49% of them actually returned to normal. This you're seeing in adults as well as in kids. And if you do see that, it's very common. Now we are going into the fall. You're going to see a lot of viral illnesses. Any viral illness can do this. Alzheimer's can do this. Parkinson's can do this. So there are several of them, but this is COVID pandemic. So first thing that's going to come out is, yes, get your testing done and see where you stand.
Okay, thank you. Dr. Maneesh, your Prime Minister there, Honorable Mr. Boris, has really kick-started a mission to reduce the weights in the Brits. I think 60% are overweight. So going on and furthering our discussion regarding the fitness level, what are the things you see which will really make some policy changes in UK and Europe?
So I think, as you know, Boris Johnson himself was admitted to hospital. He was in ITU for a few days, and one of the reasons, he's quite a fit person, so he does quite a lot of cycling, but he's overweight, and I think that was one of the possible contributory factor. So the government, I think by next week, they are coming with a policy where they are going to actually ban lots of these fast food deals where you get one pizza for free. So they are going to ban all those deals here. And they are actually officially urging people to reduce their weight so that they are ready for the second wave in autumn. So that probably is going to come. So I think that just emphasizes the fact that everybody is recognizing now that physical activity, your fitness level, and your lung capacity is vitally important actually if you want to reduce your severity of COVID illness in future. So I think that's going to be the official line in by next week.
Okay, thank you. I think we need to learn and make some policy changes here and make India fit too. Dr. Ravi Mehta, the next question is for you. Successful health system reconstruction requires planning, coordination, and leadership. Now that the whole system is crumbling down due to sheer volume of cases, patients are running pillar to post. We are getting calls from friends, family, patients, for help. It is heartbreaking. What else can we do at this juncture? I believe you have presented your plan to the higher authorities in Karnataka. Would you like to elaborate on that?
Yeah, so basically it came down to the fact that our COVID curve, as one would call it, is very different from what the US and the UK have seen. They just got it, they had to deal with it, and they formed whatever policy had to come on the ground, and that's how you heard all these plans. For us, we had all the time in the world. We then saw everything, we locked down, we thought we're good, we thought we're going to prepare ourselves. Well, guess what? It didn't happen. We went through the large hiatus, plenty of latent time, complacency, and now when it's hit us in different parts, it's just helter-skelter, patients running helter-skelter. And if any data person could just map it, you will see the headlines in every city. Mumbai, Delhi, Andhra Pradesh, which is Hyderabad, especially in some cities, Chennai and Bangalore. The same headline has gone state on state. Patients running around for beds, we don't have beds over there, care is a problem, and so on and so forth. I think we focused too much on the wrong things. We had epidemiologists giving us horrible predictions, and they're still all over in newspapers right now. We bought all the wrong machines, the ventilators. We talked of beds, and beds is not the only thing. You have to talk of equipped beds, beds with manpower, equipment, infrastructure, and round-the-clock availability for weeks together. None of this has been addressed by most of the task forces or most of the planners. I'm sorry, not that I want to create so much of a disturbance, but it sets the stage for solutions. So in the midst of this, when we said that now what you are trying to do now is ramp up healthcare, everybody said, get the beds up. Guess what? Shalini, you and I work in Indian hospitals. You cannot ramp up these beds. Healthcare workers took this entire latency to run. Our nurses from Kerala ran home. Everything was all over the place. Healthcare workers were not willing to come down. And unlike Rama's and Manish's lovely hospitals where they could get X, Y, and Z, only a year nobody was willing to come and work. So we went through this particular, amazingly never seen before, complete collapse of the system. So now it comes down to, if you can't ramp up healthcare, can you use COVID knowledge to try and at least reduce the burden of healthcare by not irrationally putting them into the hospital? And Kunal has heard some of this. He's been part of a presentation we made. So we pitched this 5 weeks ago. Impetus for this is what is the first slide, Shashi showing over there. The problem statement was very clear that can we have a point of care or shift it to their particular place, which is home or anywhere else, a facility where they are in. Can we give them care for the patients who don't require to come to the hospital? So if we can triage them there, form a plan for them there, keep them there, and then avoid them coming to the hospital, you can save the most valuable resource you have, which is inpatient beds at this point. And the impetus was that when we had in Mumbai, where we did a medical school and all, people were running around all night, going hospital to hospital, being refused, and there's mortality, and mortality doesn't come out. Mortality stays under the radar because it's not easy to talk about it. So that is when we thought that let's look at COVID care data, and COVID care data said that first of all, the mild guys, which is 80%, never should be in a hospital. Then the mild guys with comorbidities who have a propensity to get worse also do not need to be in a hospital. They can probably be there in a better monitored setting. And is the system mature, understanding, and capable of putting that into place? The third provocative part was, even after putting some of them into the hospital, all we're doing them is give medications and oxygen. So those guys also, if you can form a better point of care policy, you can probably, Shashi, you can go back. I'm not finished there. Just go back. So if you have a better point of care understanding, then you can actually keep them out of the hospital. So again, to come back, when we looked at this data, we formed this proposal. We said if anybody today gets fever, and this anybody is either waiting for 1 day, 2 days, 5 days, 9 days, they are not surfacing because they're very worried. So they are surfacing late because they, first of all, are worried. They don't want to go to any hospital or doctor. You know that our facilities are lying empty because they don't want to enter them thinking that they're going to get COVID over there. So they're lying under the radar. So if we can give them a platform where they call a call center or a helpline, then they get the right doctor using telecommunication platforms, which sprung up like wildfire in this country. Till last year, Supreme Court says you can't do telemedicine. And here within 5 days flat, we have a national telemedicine policy. So use this telemedicine, use a smart dog. Now, where is the dog going to come from? We know that anybody above 60 in the Indian healthcare spectrum, 99.9% are not coming to the hospitals. They're doing telemedicine. So if these smart, proactive, guys who've got large number of patients can be roped into this workforce, they will do our e-consultants, e-experts, and then they will do the following. They will triage the patient as to the seriousness into the categories which are exemplified in so many guidelines. They will establish the need for tests, which is where Kunal and his ability to put things more efficiently comes in. They will assess the need for oxygen therapy, which is also much easier because India is now bursting with 800 rupee oxygen oximeters, which are available in every Tom, Dick and Harry. It's become a pawn shop syndrome, I think, right now. And then they decide that where is this patient? Can he be taken care of his point of care, or do we need to get him to a hospital? So that was the whole idea. Then it became more provocative that in the metros, when what you want, you can't get a bed, can we at least give them the beginning point of oxygen therapy so that they are not floundering with all these entities like happy hypoxemia and all that. If you take care of the oxygen requirement, you have a strong ability to potentially impact their long-term outcome. So if we can get them oxygen with concentrators strategically placed along the city with help from a system such as the government or somebody who's quite strong, then we can even give them care or even prevent hospitalization if the bed doesn't come up. Then if they need a bed, then is the system capable of creating a central bed allocation system between the government and the private, which can channelize them to the right bed? So many points, not rocket science. It's something which we do every day, Shalini. You will be calling your patient, you're doing the assessment, you're trying to decide hospitalization, you're trying to decide where the bed is. So you do it as an individual. If the system does it, then we can make a lot of difference. And then the COVID cute points, as I call them, prone position. If the guy tells him that, okay, wait, your bed is coming, at least lie down prone or on the side, it has a remarkable impact on outcomes and so on and so forth. So many things will come on the ground, which will potentially impact the care. And that was the premise of the whole thing. Shashi, the next slide. And so, of course, the advantages are intuitive for a medical crowd. I don't need to put this, that basically for patients, they're getting left shifted early care at point of care, and even them trying to give them a bed when they're running around and they flounder. As we speak, I went on mute because I'm taking 4 calls for beds and trying to tell them what to do and so on and so forth. So that is the status which is still going on in our cities at this point. For the system, Shashi, if you can click it. For the system point of view, obviously you have patients who have a triage. The system knows what we're dealing with. We're collecting data. Shashi, just click the slide. We're collecting data. We're helping them, and you're saving your most important resource, the inpatient valuable bed, which is not available at this point, come what may, where the ramp up is very difficult. To give you an idea of that, at least in countries like ours, if you averaged an X capacity, COVID capacity can never be more than 0.5 to 0.6 because of manpower, equipment. I mean, at this point in an ICU, we've never had ICUs full of guys who are on either NIV, HFNC, or ventilators. For that, you require infrastructure, staff, PPE, turnover, massive concentrators, the oxygen supply, it should not run out, and so on and so forth. So anyway, to cut a long story short in the interest of time, this is the point of care plan we proposed with advantages for patient care, advantages for the system, left shift the care, collect data, run on the ground with it. And as Rama was pointing out, or Maneesh was pointing out, this is going to go on for weeks and months together. If you have a plan in place, you can put all your plugins. Kunal will come with new tests, treatments will be modified, data will be helping us, and so on and so forth. This is the plan we touted. In the story of the last 6 weeks, put it to multiple stakeholders, started from Mumbai because that was burning and Bangalore didn't believe it was required. I actually put it to Bangalore people, and I was unceremoniously told we don't have cases out here. We went to Mumbai. Mumbai task force took it. Then the task force leader himself got admitted with COVID and with HFNC. So that was something which was lying in the background. Finally, we've come back to Bangalore, where we have, I think, our local Bangalore South MP who's trying to pick it up with using a force, using a team, including Kunal, to see if this can be implemented on the ground. So in its actual pure capacity, you will reduce the inflow responsibly. You will take in the inflow with caution. You will then try to discharge them also using these doctors quickly so that you can keep them out, and you'll have a safety net in the whole concept. Basically joining the dots, crossing the T's and dotting the I's can really impact on COVID care was the entire proposal on the ground. So it's being vetted as we speak. In the next week or two, we should see more option. You'll see these words touted: point of care, case manager, and so on and so forth. And let's see how far it goes.
Thank you so much, Ravi, for this out-of-the-box thought, which might benefit, thousands and lakhs of people. With that, I go to Dr. Sachin. Dr. Sachin, yourself, besides being an administrator and director, you are a highly trained surgeon, laparoscopic and bariatric surgeon yourself. What is your take on whether elective surgery should be done or not? And there has been a recent statement by consumer panel that consent forms for medical pre-printed consent forms are unfair trade practices. So what would be your thoughts on that?
So again, Shalini, one thing is, see, elective surgeries need to be done, as Ravi very clearly pointed out, that there has to be a Chinese firewall between, COVID and non-COVID. So in India, there are enough. See, we cannot leave people not doing elective surgery and making those elective surgeries in the emergencies. Otherwise, there'll be other diseases which can kill sort of people. But yes, there is a very clear-cut guideline. If the cases in your cities, they have plateaued in the last 15 days, yes, you can. Unless the city is burning like Bombay and Bangalore or Delhi, you can definitely take up elective surgery. It should be done. The second part of it is adequate PP is the norm. So the doctors, when I in our hospital, we have made some reusable PPEs. Emergency OPD, everybody needs to be in a PPE now. That is the norm, because otherwise what will happen is that there will be so many doctors will be quarantined, because the number of positive cases in India will definitely is going to rise. As I really don't want to go into that case scenario. And the third and the final thing is that, yes, if while doing when you are doing a positive case, you have to take a very different precaution. So as Dr. Kunal said, these tests not being available pre-operatively is a challenge in a big country like India. So I think as Ravi said, that we need to have a lot of hospitals treating COVID. We need to have a lot of labs actually doing COVID testing, even in the smaller cities in India.
Okay. I think rather than coming back to you, I would also like to have your final thoughts, because I think we have 10 minutes left and we have to take question and answers. Sachin, in 30 seconds, what would you like to communicate?
I will just communicate in 15 seconds. Thank you very much. Wonderful, time. And the thing is that we have to become battle hard. Challenges, questions will be difficult. We have to act fast. That is the one thing. We have to act fast, fail fast, and learn. We don't have to worry about, failing. Any which ways we will fail. So let's not get worried about failing, but let us act fast.
Okay, thank you. And stick around. We will have few questions, so stick around for 10 more minutes. Dr. Kunal, your final thoughts, very briefly.
So my final thoughts just rely on the fact that we definitely have to ramp up our testing. As Dr. Sachin rightly said, that it has to penetrate the smaller cities, the smaller towns. COVID no longer is a disease which is remaining in Bombay, Delhi, and Bangalore. It has penetrated the tier 2 and the tier 3 cities, and with the kind of population density we have in India, although we did start off with a very nice lockdown phase, where our curve and the plateau was not exactly like the sinister sorts in US and other countries, but we have reached, we are the third largest in terms of number of cases now. So we have to be very careful, and we definitely have to test more and more people. We have to come up with novel technologies. We have to start testing people with elective surgeries. We cannot put them on hold. And from the government's perspective, we are definitely looking at, from Karnataka's side, Dr. Ravi's proposal is really, really nice. And we are set to roll it out under the office of our Honorable MP. So I would just like to say that, every warrior has his moment of glory in defending the borders. This is a moment of glory for all the healthcare workers. We are facing a pandemic like we have never seen before. Probably none of us have seen before in our lifetime. So we really have to hold each other's hands together, take care of ourselves, and take care of the community at large. Thank you.
Thank you so much, Dr. Kunal. Dr. Rama, I would like to have your comments as well.
This is absolutely an unprecedented situation for us, but as humans, we evolve, we adapt to it, and hoping for a 50% or more effective vaccine, so we could get a handle on the situation. And I guess there are some phase 3 trials going on around the world, and United States has started in collaboration with 3 of the companies. Unfortunately, they need patients from countries that have the largest infection rate, and which includes United States, India, Spain, and South Africa. So we are all in this together, and we will get through it. We need to take care of ourselves and everyone around.
Thank you so much for those positive notes, Dr. Rama. Dr. Maneesh, I would like to come to you now. Your final comments.
Yeah, I think what I would say is vigilance is the key. Really look out for atypical symptoms, even though you're not suspecting COVID. And I think watch out for post-COVID complications now, because you have already started seeing some things. So I think vigilance is the key at present if you want to be safe.
Thank you, Dr. Maneesh. Dr. Ravi, over to you. What would be your message to all the doctors out there?
I'd rather put a system message. This is highly Darwinian. As Maneesh pointed out, it's a survival of the fittest, and it's not only the fittest individually. It is systems, and the entire global community who works together can actually get out of this. And so that is what is going to help us. And the second message is, do not assume that healthcare is ready to handle it. Put all efforts possible to either augment or unladen healthcare. That will get us somewhere, at least in the Indian scenario, and most people who are thinking in the third world scenario.
Oh, thank you so much. So I would summarize it as though we know we love the clear blue skies and the pure fresh air and the chirping of the birds and the return of the dolphins and the sighting of animals in the urban areas. But these are definitely things to rejoice, but the lockdown cannot go forever. So what is the new normal? We have to promise ourselves we're not going to revert back to our highly polluting days. But I think the lessons we learned is, as they say, no crisis, never waste a crisis. That, we know what happened to Dr. Lee. He was silenced. This tragedy highlights the critical importance of honesty and transparency. That's of paramount importance. There should be transparency in big corporate setups, IT sectors, or hospital or factories. Report it. Otherwise, the COVID infection would spread exponentially. And because it's a global webinar today, I think we have to look at global aspect as well. Unified responses to pandemics rather than diverse, disconnected strategies. Accountability. I think those who make decisions must be held accountable. And doctors can't do it alone. You need government, you need improved nutrition, sanitation, vaccination programs. I think now the patient will be more open to hear to us when we say, please get vaccinated for pneumonia, pneumococcal, swine flu. Earlier they used to make all kinds of excuses. And I think applying modern methods of disease prevention, like Dr. Ravi was saying, don't forget other diseases. So in India, unlike UK and US, we are set. We're already hit by dengue. So we don't have to, the BBMP or our authorities should not forget the mosquito control prevention programs, public education program to raise awareness. I mean, WhatsApp has done a good job of creating the scary situation. Sometimes COVID fear is more deadly than the actual COVID because the way the public is behaving. And definitely we have to reform the medical education. Only 4 things I would like to point out. If at a basic individual level, what we can do is, please tell our patients, we are already doing counseling patients psychologically, telling them to eat properly, nutrition. I think we can add the smoking cessation aspect, which I'm running a campaign, Quit in Quarantine, because now is the time to heal the lungs. Because as we know, as some studies have shown, which have been in NAGM and Chinese studies, that people who smoke end up in the ICUs and ventilators and have severe complications. Adult vaccination, as I mentioned, especially with the people comorbidities, need of the hour. And don't ignore other prevalent diseases in your community, and lose weight and get fitter, as mentioned by Dr. Maneesh Bhargava. With that, I think I will like to take some questions. And again, would like to thank all the panelists for taking their time from the busy schedule and articulating so well in such a short time, and putting their thoughts across and sharing their experiences and even their personal stories. Thank you. And with that, I will read the first question, which comes for Dr. Kunal. At which point of infection does the patient start shedding infection to others? Is it from the moment the patient acquires the COVID-19 virus, or is it after a few days? Anybody?
I think, I would let Dr. Rama answer that question better.
Yes. No, sorry, I read it because the person had written like that. Sorry,
no, that's all right.
Usually, any viruses, the incubation period or the prodrome phase is when they're highly infectious. For COVID-19, the incubation period is from 2 days to 2 weeks. So the patient can be infective up to 10 days is what our CDC guidelines have been saying.
Okay.
So when it comes to somebody, the patient will ask, okay, now I'm COVID positive. And it's been, I've been positive, I went again, and it's been 2 weeks and I'm still positive. What do I make out of this? And do I really need to go back and quarantine myself? No. The thing is, if the patient is afebrile, asymptomatic, isolating these PCRs, replicating competent viruses is close to 0 by day 10. So you might only pick up as false negative or a dead genome on the PCR, and they are not infective as long as they are asymptomatic. And I will allow Dr. Kunal to pick it up from there.
Yeah, so I think Dr. Rama has just given a very nice ground for me to just elaborate a few points from the testing perspective, that we need to understand that there is a question I'm most very frequently asked about prolonged PCR positivity. So we have to know that any viral particles which might not be a whole live virus, even those can be picked up in the RT-PCR and they will continue to show positivity. But what we have to also look at are the cycle threshold values, which we have started giving in all our RT-PCR reports. So CT values which are beyond, let's say, 36, 37, at beyond those levels, even if we do detect, we have to understand that these could probably be dead virus particles, and we don't really have to do much about them. What we also have to understand is that a low viral load can also show RT-PCR negativity, and there are issues when people have negative and then they have tested positive again in RT-PCR. So we have to make sure that there is no contamination in these scenarios. That can also happen. To put a dictum, less than 10 to the power 6 copies of virus per ml, we generally don't detect in RT-PCR. And even when we try to isolate these virus on viral cultures, we will probably not get much answers. So as Dr. Rama ideally put it, this has to be, the RT-PCR has to be read in a correct clinical scenario to best be able to take a judgment on the patient. Thank you.
Okay, and that question was from Dr. Rumi Daruwala. Thank you again for your question. She asked a second question. Does IgG antibody indicate patient is immune to COVID-19?
So I would like to go back to the chart. IgG is an antibody that usually comes up in the later stages of the infection. So it can also indicate that the patient is in the later stage of this chart. So you can see that IgG antibody is positive when the patient is in active phase of infection. Just look at the table below. IgG is also positive when patient is in the late or recurrent stage of infection. So and it is prolonged till about 3 months. It is also positive when the patient is in the recovery stage, and the PCR result may be false negative. So I think this graph and this table answers that question pretty well.
Okay, thank you, Dr. Kunal. We have a question from Dr. Piyush Bafna from Middle East, and he's asking about the skin lesions. Anybody has experienced what type of skin lesions they are? Are they similar to allergy or are they common?
I think Maneesh had some experience.
So we have seen few cases of sort of a maculopapular rash on the torso, which was more or less similar to what you see in a drug reaction. I have seen a couple of patients with leg ulcer, acute leg ulcer present or appearing within 2 days' time. Very typical of a diabetic ulcer type, but very sort of acute. And there have been lots of reported cases, at least in UK, of chilblain type lesion in throat, which can last for weeks and weeks. So some of these lesions are very similar to drug reactions.
Okay, thank you. There are some comments as well. Dr. Pankaj Anand says he really found the information very useful, and thanks Dr. Ravi Mehta for the initiative. And another question asked by Dr. Piyush Bafna is, what is your imaging protocol? I think he means about the X-rays and CT scan, how important they are in the management. Dr. Ravi Mehta, you want to take it?
Sure. Okay, you guys can hear me? Fine. Yeah. So basically, it all depends on the stage of COVID. Most of the CT data was very revolutionary and provocative. We never expected CT scans to come so vociferously in data. So it turns out, as Kunal's data, Kunal has pointed out that RT-PCR, we take the average ballpark figure of 70%. A well-done RT-PCR is 70%. But if you are mild category onwards, the CT scan will take your sensitivity all the way to 95 plus if you're in COVID season. If you're not in COVID season, it's more challenging because a whole bunch of those mimics can do it. But typically with COVID patterns being described in COVID season, high pretest probability, CTs took the diagnosis to a very high sensitivity and specificity. The second thing was it also shows alternative diagnosis, which is something we've also learned from CT scan. But again, to implement CT is a little, you balk at the thought of doing CT scans, but it's become more and more common because now the radiologists and the systems are more used to doing it. The actual data on the ground takes a very high, gives a very high amount of relevance and importance. Once they get admitted to us, we don't do anything. Then the only reason to do a CT scan down the line in patients who are moderate to severe category is if there is some therapeutic plan based on it. So by and large, at that point, we'll not do many CT scans at all. It's mostly looked as a diagnostic tool and a potential therapeutic intervention mindset, which will make you do a CT scan for a COVID who's moderate to severe. This is the writing on the wall. As you pointed out earlier, non-COVID, if you suspect a non-COVID diagnosis or a primary lung issue with super added COVID, it has value addition. ILDs, bronchiectasis or something which has developed COVID, it will help a lot in that sort of situation.
Okay, thank you, Dr. Ravi. I think the similar question before we had answered was asked by Dr. Pawan Goyal. He had a question from Delhi. I think we have answered that. And another question asked by him is, I think Dr. Rama can take it. It's in hydroxychloroquine and Fabiflu, I think have any role in moderately sick patients. So how is your experience with hydrochlorothiazide? I know your president had commented about it in the early part of the disease.
So as I did mention early, yes, early on the disease, we were really in favor saying that hydroxychloroquine was added to the treatment regimen. But looking at all the studies as of July 15th, that emergency utilization authorization for hydroxychloroquine has been revoked, as it did not show any kind of, there are several different studies that have come out and did not show to be, it did not delay the hospitalizations, did not help in progressing to mechanical ventilation, nor even the post-exposure prophylaxis did not seem to have helped. So as of now, we're still needing data to really say this is useful or not. So as of now in the United States, it is only going to be used under clinical trials from Infectious Disease Society of America. Otherwise, I think we are holding off on that drug.
Okay. And I think I would request you to take the next one also. This is from Dr. Sai Gandham, ophthalmologist from Albany, New York, USA. He's curious to know what are the eye findings in COVID-19, if you have come across, and how's the experience?
So far, the only, not much different from any other viral diseases. The common complaint that we got is conjunctivitis. However, there have been some case studies that have come up, case series of 38 patients with epiphora, which is excessive watering of the eyes. And this is also very supportive, and there is not much to do with it. And that, I think these are the two that came up, which is conjunctivitis and epiphora in COVID-19 patients.
Thank you. I think I would like to like Dr. Ravi to answer the next question. This is a question from Dr. J.A. Osadie. I hope I'm pronouncing it correctly. Pulmonary medicine from Lagos, Nigeria. So Dr. Ravi is asking, will inhaled steroids be of value in management, especially early on?
Yes, it's a lovely question because the data is now inundated with cyclosinide. And I think, Rama, you have this Texan doctor who's got a very erudite 23-minute typical media presentation where he extols budesonide, that he's given all his patients budesonide and 100% recovery. And I would warn the group and the listeners, if anyone says 100%, I think you can just shut off the presentation at that point, because it's not true for this disease at all. So people have touted it. They're saying it's because it's a local inflammation. And so they give local anti-inflammatory without the side effects of systemic steroids. So local anti-inflammatory steroids, it has a great impact. Nobody knows at this point. I mean, it's just there out there. People are going to use it. Patients cough. We know that. We know they get a lot of sore throat. Rama pointed out this rhinitis, which is just persistent for a while. But whether that's going to respond to inhaled steroids, which is a double-edged sword. We have been struggling for the last 20 years to say that inhaled steroids increase infection in chronic lung disease and they have to be avoided. Now in a viral syndrome, where we are trying to talk of the fact that will inhaled steroids make a difference? We don't know at all. But cyclosinide and budesonide, these two drugs have been talked about. The other thing, if I have a minute, Shalini, and let me comment on the HCQ story. The HCQ story, I don't think is done and dusted. I think it's going to go on and on. India still loves HCQ.
We probably lost.
Lost Ravi. I think somebody else will have to complete it. Rama or Maneesh.
Okay. We can go ahead. So I think he'll come back and continue his thoughts. There's a question from Dr. Gordon Douglas, ophthalmologist from Calgary, Canada. Anybody can take the question. So he is asking, which country is the most reliable in estimating the percentage of symptomatic versus symptomless COVID cases? I think what he means is who should he trust? Which country is giving the correct data and which country is hiding? And what is the international experience of using steroids to treat severe COVID symptoms?
Well, I would leave that up to Dr. Mehta.
Yeah,
I think he would be an expert. But yes, as I did mention.
Rama, he has left, so it is up to you and Maneesh.
Oh, wow, no pressure.
Sorry, what was the question?
Oh, he's there.
Am I audible or visible or both of them?
No, actually now you're audible. I'm just saying this is a generalized question, generic question, like what is the international experience in using steroids to treat severe COVID symptoms, would you, I know we started as soon as the pulse ox goes down 94% and, hit early, hit hard, it has utility in severe cases too. That's the question.
So let me answer this for once. There has been a UK trial that was done regarding with dexamethasone, and it has shown that, where did I get that? I don't think I can get my slide up.
Don't worry about that, Rama.
Yeah, it was a 20,000 patients there that they looked into, where it shows that there was reduced death by 35% in ventilated patients. And patients who were requiring oxygen, 20%. But there was no benefit seen in patients who required no respiratory intervention. So this is from the UK recovery trial of using dexamethasone, 6 milligrams PO or IV daily for 10 days. Maybe Dr. Mehta can comment on this as well.
Yeah, so basically steroids came back, as we talked about, we talked about infective, inflammatory aspects, and on the ground, a lot of interest started to come from the US and the UK, that steroids given at the right point in the desaturating cohort is going to make a big difference. So first, the Michigan, we heard a lot of news from the US, not validated, and the WHO said no steroids because it will delay viral recovery, increase viral shedding, and so on and so forth. And then came the results of the UK trial where dexamethasone was used, and of course, the media picked it up saying so many lives could have been saved, and so on and so forth. Scientific part, inflammatory phase, your patient's deteriorating, going on oxygen, reasonable infection rule out with clinical WBC procalcitonin, steroids can be given. UK guys use Dexa because Dexa is their drug. The US guys have used Solumetrol because Solumetrol is more a US drug. So any of them can work in the right dose. Indian dose is 8 milligrams of Dexa as against the 6 of the UK. Medrol goes as 0.1, 0.5 to 1 milligram per kg. Duration 5 to 10 days. Watching for infection significantly impacts the treatment outcome. My feeling but it delays the RT-PCR conversion. We're looking at longer and longer RT-PCRs, which is getting these guys stuck in the hospital. So we have guys exercising with COVID now because they can't discharge them because of positive RT-PCRs and our rules and so on. So that is the steroid take at this point. The inhaled steroid component asked about, again, an extrapolation, not validated, more a part of an interesting YouTube video than a practical recommendation.
Thank you so much for rejoining. A technical issue, I think. Dr. Maneesh, Dr. Preeti Goyal from Delhi is asking for how many days a positive COVID person should monitor his oxygen level after testing positive if asymptomatic. How often and for how long?
I mean, most of the lung complications are seen within sort of 3 to 4 weeks of being picked up as an asymptomatic or symptomatic one. So I would assume that the home monitoring with oxygen should be for maximum of 4 weeks. I mean, if you are asymptomatic and if you don't develop any symptoms, including respiratory, then I don't think you need to monitor more than 2 weeks really. But if you are symptomatic, I would say it should probably last for 3 to 4 weeks maximum, because that's the time period when you're going to see lung-related complications.
Okay, thank you. This is our last question we are taking, and then we'll have to wrap it up. So bear with me, it's a long question. Asked by Dr. Suresh Mittal, medicine from Delhi. A doctor fully asymptomatic, that's the case I'm presenting, admitted with ureteric stone colic, investigated for surgical intervention, found RT-PCR positive. Now he's COVID-19 patient with a very high IL-6 levels. On day 3 and rest all investigations, all inflammatory, including CT, are normal. Saturation 100%. And should we use tocilizumab 800 milligram, dexamethasone, low molecular weight heparin to avoid any complication? Now, since he has received tocilizumab, now when he can undergo the surgery for his ureteric stone? I had to read this question. It was diligently written.
Okay, all right. First of all, yes, during this COVID pandemic, there are certain diagnostics that took off, which are the CRPs, the IL-6 levels, the procalcitonins, and the LDH. Not every patient who has these high are COVID, even if it is COVID positive patients who are asymptomatic. For all from what you're telling me, it looks like the patient may have is incidentally COVID-19 positive. He's asymptomatic. His main issue is renal colic. So if you have a kind of a septic picture, even in sepsis, you will see an IL-6 level high because it is an inflammatory cascade. So you're going to see all these levels high. So even, tocilizumab was most likely not the first line of treatment for this particular patient. Could have been to relieve the obstruction with the obstructive uropathy and treat the underlying cause than the IL-6 number. And even if the patient has received tocilizumab, have to understand these drugs are used as immune modulators for rheumatoid arthritis. And those patients, when they do come in, they have received their tocilizumab as a regular dosing for themselves. Doesn't mean that we delay their surgical intervention.
Okay, thank you.
But just keep in mind that yes, it can cause serious infections as well, tocilizumab.
Okay. A final one. This is from Dr. Meenu Batra from UK to Dr. Sachin. She's asking, Dr. Sachin, which role do you enjoy more, being the administrator and the director or being a hands-on laparoscopic bariatric surgeon?
I think it's a combination, Shalini. I'm just putting my thing on camera and think there's some problem in my bandwidth. I think doctor has to evolve. He has to be the leader, be the torch bearer, especially so in this corona time. So everybody who is a doctor has to be a leader, an entrepreneur, and somebody who shows the way out of this corona thing. I think doctor is very important in this area. Thank you.
Thank you so much. And this is our final wrap up. And this is the Corona Namaste to everybody who really, I know we shot over time, 18 minutes, but it was lovely having you. And I am sure people who are listening also had a good time like we did conducting. So thank you so much.
Thank you.
Thanks.
It was a pleasure.